All right, so tonight we're going to cover the principles of pharmacology, chapter 11 first. And again, the chat box is open. I can view the chat box here if you guys have any questions you would like to ask that are private. You can do it that way, or you can do your answers on your chapter quizzes that we do at the end through the chat box as well, as long as I see people actually participating in it. All right, so we're going to talk about pharmacology. So actually, this applies fundamental knowledge to the medications that the EMT may assist or administer to a patient during an emergency. Pharmacology is very important for you guys to understand because we are administering medications, some that can actually kill people if given in the wrong situation. That's where your assessment comes in prior to actually giving somebody a medication. We're also going to cover the principles of pharmacology, medication safety, and then kinds of medication used during an emergency that we have. We're going to talk about self-administered medications, peer-administered medications, and we're going to talk about the assisted administered medications to a patient, the different routes of entry we're going to be utilizing. We're going to cover medication names, the effects of the medications, the actions of the medications, the indications of a medication, and the contraindications of a medication. And keep in mind that there are different names for medications as well. When you talk about medications, there's a trade name, there's a chemical name, and there's a generic name, and they all mean the same thing. The last, we're going to talk about complications, what routes of administration, whether it be through oral, rectal, intranasal, things that you might be utilizing for your level of care, including intramuscular as well. Side effects, interactions for the medications, and then dosages for medications administered. So from here on out, anytime we give a medication, we want to make sure that it's the right person, the right time, the right dose, the right documentation, and we want to make sure that we're looking at how they're administered as well, but also the dosages are very important because pediatric versus adult, completely different world, because some are weight-based and some are not. So you got to make sure we're looking at all that. And then the added scope of medications we're going to be utilizing for New Hampshire operations as well. All right, so medications are an important intervention. So looking at medication administration itself, if without medications, a lot of times these patients can't get better. From pain management, and yes, EMTs in New Hampshire have pain management medications to include Tylenol and ibuprofen, both oral or otherwise known as PO medications. So important stuff. We have nitroglycerin that we can help assist with a patient that's having chest pain as a vasodilator to make the vessels bigger to take and allow more oxygen transport. We have other medications like aspirin. We have oxygen, which can make or break a patient with low SpO2 readings. So there's a lot of different important interventions that we can use, and medications just fit into that. And it's all part of our treatment plan and how we move forward. Medications may alleviate pain or improve the patient's condition. And believe it or not, nausea can actually be relieved with oxygen sometimes as well. If they're a little short of breath and nauseous, a little bit of oxygen through a nasal cannula can make a world of a difference. Also, another thing with nausea as well to kind of add to that is just sniffing alcohol preps as well. You can have them sniff it 3 times, and then a lot of times they can help relieve the nausea as well, which is actually part of the New Hampshire protocol. Failure to administer medication safely and completely and competently as well can lead to serious consequences for the patient, including death. And one of them would be like epinephrine intramuscular for anaphylactic shock. If given into a vein, can actually kill somebody due to the concentration of the medication that's actually there. So as an EMT, you will be administering medications. You'll be helping patients self-administer medications like an MDI albuterol inhaler, nitroglycerin, and things like that. You're going to be asking patients about medication use. So you need to understand what they're taking and have kind of an idea of what medications they're taking that will have an effect on the body. And then also report patient information to the hospital personnel on what they are taking. And it's not just saying, oh, well, they take, Plavix. Well, if they take Plavix, well, how much Plavix do they take? Do they take 5 milligrams, 10 milligrams? Things like that. So how does medications work? Well, pharmacology is the science of a drug. With that being said, a medication is a substance used to either prevent or treat a disease or relieve pain. To give you an example, pain relief would be like Tylenol, ibuprofen, morphine, fentanyl, Dilaudid, ketamine, Toradol. These are all different, from EMT to paramedic medications, but they relieve pain. I wanted to prevent or treat diseases like chronic obstructive pulmonary disease, like COPD. Oxygen helps with that. That's a preventative medication that we're using, or a type of treatment for the disease of COPD. And there are other medications out there as well that are like steroids and things like that that go to the paramedic level. So it depends on the medication you're giving and what we're using, whether preventing or relieving pain. Then we're going to talk about the pharmacodynamics, which is a process by which the medication works on the body. So we start talking about like half-lives of how long the medication stays in the body for. And some stay in for 40 to 50 days, and some medications stay in for 24 hours. Some only last for 6 seconds. It all depends on the medication that's being administered. So an agonist causes a stimulation of a receptor. An antagonist binds to a receptor and blocks other medications or chemicals. So an agonist would be something like epinephrine, which stimulates the sympathetic nervous system, it can cause elevated heart rate, but at the same time, it's also vasoconstricting to allow for better airflow if the patient can't breathe. An antagonist would be something that binds to a receptor, and that would be something like Narcan. So if we're giving intranasal Narcan, what we're doing is there's opiate receptors in the body, and what's happening is obviously when the opiates or opioids get into the system, into these receptors, causing someone to get high, Narcan doesn't remove the chemicals in that receptor, it just blocks any more from coming in. So it's kind of like a club when people are partying inside and a bodyguard is standing outside, or a doorman, and they say, you know what, we're denying any more access. We're stopping that from happening. And that's what an antagonist does. It antagonizes and stops anything from coming in to allow that medication to stop and finish inside the system. That's what Narcan does. We're also going to talk about the dose, which is the amount of medication given, which depending on weight, age, and desired action. So everything that we do in EMS that's weight-based is done in kilograms, not pounds. You need to understand how to convert that over. So there are long equations, but there's a down and dirty version that you guys should know about. So the way this works, and if you guys want to write this stuff down, you're more than welcome to. You take the amount of weight. So we're going to say the patient weighs 220 pounds. To get that into kilograms in the down and dirty way, we're going to divide by 2 and take off 10%. Now, I know that sounds like a lot to figure out, especially at 3 o'clock in the morning. So to figure this out, take 220, divide that by 2, right, which would be 110. And then what you do is you take the first 2 digits of the 3-digit number and subtract that from the 110. So 220 would be 110, so 110. Take the 11, subtract that from the 110 would be 99, so it would be 99 kilograms. Does that make sense?
Yeah.
If you guys write it out, it'll actually make sense a little bit more. So if they're 300 pounds, divide that by 2 would be,
Yes.
what's 300 divided by 2?
150.
Okay. Minus 15 would be
135.
135 kilograms. So now let's say you got a kid, okay, and let's say they weigh 50 pounds. We're going to divide that by 2, it would be 25, and you take the first digit, because it's only a 2-digit number, subtract that, so it would be 25 minus 2 would be 23, so it would be 23 kilograms. So if it's a 3-digit number after the division, okay, you take the first 2 digits and subtract that off your number. If it's a 2-digit number after your division, take off the first digit, subtract that, and that's how you get kilograms for that one.
Sorry, I was writing this down. So the 50 divided by 2 equals 25, and then you minus the 5?
Nope. 25, your first digit's 2.
Okay, minus the 2.
Yeah, minus 2 would be 23 kilos. And the best way is to practice it and know like more of the generic ones that are out there. You know, if they weigh 200 pounds, 100 minus 10, after that, would be 90 kilos. That's how much they would weigh, 90 kilograms. And if you took it down and broke it down, the true fashion of this, of the breakdown, is your total amount in pounds and divide it by 2.2. So if you do that, it'll come out right around the same number, pretty close to the same, like within a tenth or a hundredth of a point within the patient weight. But at 3 o'clock in the morning, you forget your phone at home and you don't have a calculator on your ambulance, you got to figure it out. That's an easy way to do it. But the true equation is take the patient's total weight in pounds and divide that by 2.2, and that gives you your kilograms. But the way I taught you is the EMS street method of how to figure that out. All right. Next. So action. So the therapeutic effect. What is it actually going to do for this patient? So if I give somebody nitroglycerin, the action of the medication or that therapeutic effect is going to be something called vasodilation. So I'm taking the vasculature of the body system and I'm making the vessels bigger, making bigger hoses. By making bigger hoses allows for oxygen transport better, because if there is a clot somewhere in the system, so plaque buildup that's causing chest pain, the nitro opens it up bigger so that way there more blood flow can go and the heart will be happy with that, and hopefully it will reduce chest pain, or what they call reducing the angina. Okay, so that's how the action works. Epinephrine, same thing. The therapeutic effect of, or the action of epinephrine would be is to vasoconstrict. So if you're having a massive widespread histamine release within the body, and that's when H receptors or histamine receptors release histamine into the system for anaphylactic reaction, what's happening is you're giving epinephrine to vasoconstrict, open up airways to help the patient breathe better. So that's how the action works. The indications, why we gave it. What are the reasons behind it? So anaphylaxis, epi. Chest pain, nitro, most of the time. Chest pain, aspirin. Diabetic patients that can still swallow and can maintain their own airway, we give oral glucose to, in turn, put sugar in the system, and the indication would be that for hypoglycemia. Contraindications or harmful effects. So if a patient has an allergy to aspirin, we don't give it to the patient because it can have a harmful effect on it. That's why your sample history and looking at your signs and symptoms and allergies as your A is so important to obtain, because if you don't get a good allergy history and you give the patient the medication they're allergic to, you put them into an anaphylactic reaction and or potentially could kill them. And then the side effects are the unintended or untoward effects that are there. So I know that if I give somebody nitroglycerin sublingual, which is under the tongue, you learn the terminology with that, we'll go over that later, and they take a nitroglycerin, one of the side effects to that, which is the untoward effects, I know it's going to happen, is headaches. Because what we're doing is we're vasodilating. So that's one of the untoward effects. Unintended effects would be something like they develop more chest pain with it. It's not really one of those things that's like not intended to happen. Usually we see like headaches, they might get a little weak. We'll see hypotension, like blood pressure dropping. That's an untoward effect of nitroglycerin. But someone developing more chest pain or they stop breathing because of it, that's an unintended effect that was not planned for. All right. So the generic name, medication names, the generic name is a simple, clear, non-proprietary name, like ibuprofen. The trade name is the manufacturer's brand. So one example that would have more than one trade name would be like Tylenol. So Tylenol also has another name for it called acetaminophen. Same thing, just one has a trade name, one has a generic name. So Tylenol, acetaminophen. Ibuprofen, another name for that would be like a trade name would be like Motrin, would be the other one. Same dose, does the same thing, just has one has a trade name, one has a generic name. Other things we find would be prescription names, like over-the-counter medication names, things like that. There's other names out there like recreational drugs. So I'm sure you guys have probably heard these on the streets. I'm sure Kim can probably come up with a lot more that I probably haven't heard working in law enforcement. But there's all these different names of medications that are out there. For example, one being a speedball, where you take cocaine and heroin, they mix them together because one has an upper, one is like a downer, and they put those two together. And it's called a speedball. There's a lot of other ones that are out there. Well, I'm not going to get into a whole recreational drug education class today. It's another program in its own. But there are other things out there that for recreational drugs with different names that are out there. Herbal remedies. A lot of people are big on herbal remedies. If you haven't seen that out in the field yet, you will. A lot of times you'll see those as frequent flyers. Enhancement drugs. And some enhancement drugs would be like drugs for erectile dysfunction, like Cialis or things like that. However, enhancement medications like for erectile dysfunction can also be used as a cardiac medication as well. So don't get that confused. If you see it, does not mean that they have erectile dysfunction issues. It could be for another cardiac reason. So simply ask them, what are you taking this medication for? However, if a patient is on ED medications or erectile dysfunction meds, and you give them nitrates on top of that, already their blood pressure is dropping and they put blood in other areas of the body. But to kind of add to that, though, if you give them more, you can actually kill them. Then obviously vitamin supplements as well. So routes of administration, obviously absorption is the process by the medication that travels through the body tissue, through the bloodstream, through absorption. Common routes of administration would be PR or PO. So PR is per rectum, which is by rectum. So we can give rectal medications. One of the ones you guys will see for the rectal medications might be Diastat, which is one of those medications you can assist with, which is basically it's Valium. That can be used for people that have chronic seizures and they have their own prescribed Valium. Oral medications, or what they call per OS or PO by mouth, that's not going to be your nitro, but that's given sublingual under the tongue. And obviously, like aspirin would be PO, things like that. So we'll go over those a little more when we get into the actual medications. And Kelsey brought up also that she's known people who have had taken ED medications for MS as well. So thank you, Kelsey, for bringing that up. So some common routes of administration, we're probably going to see obviously anything intravenous is IV, which is into the vein. Interosseous, IO, is into the bone. So we have a special bone drill that we utilize called an easy IO drill. Subcutaneous is beneath the skin. So for those of you who have ever had like who might be diabetics and get insulin, they stick it into their stomach. That's what they call a subcutaneous administration. Intramuscular, which is something that EMTs will be doing, and I'll be utilizing either an EpiPen or the Ready Check Inject program that we have in New Hampshire. That's intramuscular, so it goes into a muscle, whether it be like the deltoid up on the upper arm or the lateral thigh as well. You can use that. That's the go-to site for epinephrine administration. So we'll get into those later on. Inhalation medications, so those would be like your albuterol, meter dose inhalers, and other medications like that. Oxygen is also an inhalation medication. Sublingual is under the tongue. Transcutaneous or transdermal is through the skin. So there really is nothing that we utilize at the EMT level that I can think of off the top of my head that we utilize for transcutaneous or transdermal medication. You'll see more of that at the AEMT and paramedic level, like nitropase being one of them. And then you have intranasal, which is into the nostril via a mucosal atomizer device, what they call a MAD device, MAD. And that's what we're utilizing for Narcan. And these are kind of like the absorption rates that are in your book. So sublingual is pretty rapid under the tongue. That's going to be your nitro. Rectal is very rapid because your I'll get to you in a second, Kelsey. I saw your message. So per rectum, per rectal would be the diastat. That's pretty quick acting. Anything by mouth, PO, would be pretty slow to react. So like aspirin doesn't react automatically. It's not like a fast acting. It just takes some time. It might take 15 minutes, 20 minutes, things like that, versus rapid that happens instantaneously within 5 minutes. Other medications would be like your Tylenol and ibuprofen that can take up to a half an hour to work, but it's still a pain medication. Parenteral would be like IV, IO, those are immediate. Inhalation, intranasal are pretty rapid. Intramuscular is kind of moderate. Then transcutaneous and subcutaneous would be very slow. So to answer Kelsey's for charcoal, charcoal would be a PO medication. It's an oral medication that is obviously goes down the esophagus into the stomach. And it's either going to come out either one of two ways, and depends on if there's sorbitol in it. And it's either going to come out through vomit or it's going to come out through diarrhea, one of the two. What that does is it absorbs all the bad chemicals that were ingested. So the form of medication usually dictates the route of administration. So the manufacturer chooses the form to ensure proper route of administration, timing of the medication's release into the bloodstream, and then effects on the target organs or body systems. So aspirin is not designed to be crushed and snorted. It's designed to be chewed up and swallowed because it has that type of absorption rate. Nitroglycerin, not designed for PO oral medication. It's designed to be done through the mucous membranes of the tongue, or underneath the tongue. So that way there it absorbs through the tongue and then the vascular system that way, which makes it pretty rapid. Other medication things you might find as well, as far as PO medications, is you're going to see things like XR at the end of the medication. That'd be more of what they call extended release, which are things that medications you'll take oral that will last over a 24-hour period of time. So you might see XR, those are your extended release medications. Nothing that we'll be giving in the field, but when you're looking at medications on a patient medication list and see that, we know that's an extended release. There are basic forms of medications, tablets and capsules, solutions and suspensions, meter dose inhalers, topical medications, transcutaneous medications, gels, and gases for inhalation. So like oral glucose would be kind of like a gel. Gas would be more of the oxygen. Topical medications, maybe something like lidocaine or something like that, that helps a patient with chronic pain, like back pain or things like that. The transcutaneous, obviously, that would be more of your like nitro paste, things that we wouldn't be giving in the field as an EMT. Meter dose inhalers, albuterol, tablets and capsules, those would be more towards your like ibuprofen, Tylenol, and then your solutions and suspensions that we have. I'm trying to think what ones we carry that are solutions. Epinephrine would be more of a solution, and that would be an injection type. So capsules are gelatin shelled, filled with powdered and or liquid medication. And tablets often contain other materials that are mixed with the medication and compressed. So you may see like oxycodone, things like that. Or I'm trying to think of some other combination of medication. I'm drawing a blank right now. I don't know why. We'll go with that one for right now. It's like Oxycontin, oxycodone. Might be some tablets you'll find in the field of patients that have chronic pain and things like that. A solution is a liquid mixture of substances. So a mixture will not separate by filtering or letting it stand. Many solutions be given IV, IM, or subcutaneous injection. So patients that are on insulin, that would be a solution that's drawn up and administered. Medications that you'll be giving as an EMT that are a solution or a liquid mixture would be epinephrine. And you can also do liquid Tylenol as well. That's also within the EMT scope of practice for New Hampshire. A suspension medication is a substance that does not dissolve well in liquids. Will separate if it stands or is filtered. These are meter dose inhalers. I'm sure you guys have seen these around quite a bit. Liquids or solids broken up into small small enough droplets or particles may be inhaled. You'll see these for patients that have like COPD or asthmatics, or they may be administered one of these here, or given one of these if they have like bronchitis, something like acute bronchitis, pneumonia. You may see them here in case they need some bronchodilation. A metered dose inhaler directs such substances through the mouth into the lungs and delivers the same amount each time. It's metered dosed. A lot of people with these here will have something called a spacer that goes up. You can see where the white cap is. You can see my moving my mouse on the screen here. Where the white cap is, that will come off. We'll shake this really quickly, and we'll put a big blue device at the end of this. It comes out about maybe this far. And what that does is you squeeze the medication into that, and then they take the big inhalation for that. And that will bring in the medication. So I'm trying to answer your question, Kelsey, in that. So her question to everybody was, do we have options for medications for people who have a hard time swallowing medications but do not have an issue with taking things orally? So in New Hampshire, you do. So you have PO Tylenol in tablet form, and they also have it in liquid form as well that they can just swallow. So if that's what you're looking for an answer, we do have that ability for it. Maine does not. So Maine EMS does not have the Tylenol for the EMT basic, at least not yet. Doesn't mean it's not coming down the road. So topical medications include lotions, creams, and ointments, which are applied to the skin surface and affect only that area. With like calamine lotion, hydrocortisone cream, or neosporin ointment, things like that. Lidocaine may be another one as well that you might find for different types of patches. The transcutaneous medications are designed to be absorbed through the skin, also referred to as a transdermal med, and may have systemic effects. Again, if you're doing, let's say you're doing a transfer of a patient, and like let's say in a facility, and the patient has nitro paste or whatnot on a patch on their chest wall, if you touch that with your bare hands, that also goes into your system as well. It can make you feel lightheaded or pass out. So again, if they have patches that are there, other transcutaneous medications that are out there as well, and I've been to a couple overdoses for these, mostly at nursing homes, is fentanyl patches. And we used to have this lady all the time who used to chew fentanyl patches to get high. And you get there and you're like, oh, she's an elderly woman. She's in her 80s. It's not like she's ever going to get stoned. And you take a look at her pupils or pinpoint, and you open her mouth up, and she's got like 15 fentanyl patches in her mouth. And she's getting high off that. So we end up giving her Narcan, waking up an 88-year-old who likes getting high off fentanyl. So again, don't rule that out. It might be there. Examples would be like nitroglycerin paste or an adhesive.
Could I say something about that? The nitro or the fentanyl patches.
Yes.
I worked in the jail, and there was a girl that would come in all the time, and she would have about 15, and they're very clear, and they are very naked to the eye. So if you do have to do hands-on work, obviously, just be cautious where your hands are going, because you may not see these patches on the person either. And that's when I had to strip her out, that I found all the patches, and I was, because it like glowed in the light. So just a heads up for everybody.
Yeah, that's a good point. And you're all right though. It is hard to see. All right. So if you touch the medication with your skin, you will absorb that just like the patient does. So like Kim was saying, if you're touching fentanyl patches, you don't know what they are, and you're like, oh, it's just plastic, and it's still on there. It gets into your system. You got fentanyl into your system. So again, you need to be very careful with that. Some gels would be like semi-liquid. So what we would carry for that would be like the glucose, as you see in the bottom there, or glucose 15. Those would be your oral glucose medications. So these are administered in capsules or through plastic tubes. Also, examples would be oral glucose for a patient with like diabetes. Other gases for inhalation would be outside the operating room. Mostly common used one is oxygen. In the operating room, they have different medications they're going to be utilizing to put people under. Usually delivered through a non-rebreathing mask or a nasal cannula. Those are going to be the two most common methods of oxygen delivery. The other one would be like a bag valve mask if you need to use a bag valve mask. Some general steps in administering medications would be medications should be administered only under the authorization of medical control. Now, remember that we have standing orders, okay, which are within our protocol to say you can just give these medications. Then we have medical control orders, which are orders that need to be run by a medical control physician, whether depending on which hospital you're going to be transporting to be able to get permission to either assist or administer that med. Again, look at your protocol books and find out what they are. Maine and New Hampshire, completely different, all right? Other than oxygen has always been a standing order. But nitroglycerin has been assisting a patient's own nitro, not pulling it out of our drug box, and that's a medical control order because nitroglycerin can be very dangerous if given in the wrong situation. You also need to make sure you're following the 6 rights of patient medication administration. And medication errors almost always result from a failure to follow the 6 rights. And here are the 6 rights of patient medication administration. You have to have the right patient. You have to have the right medication for what you're treating them for. You need to have the right dose of medication. You have to know the right route of administration, the right time to give it, and you have to have the right documentation, making sure you're documenting what you've administered. If you do not follow these 6 rights, a patient can become in trouble and you're giving a medication without having a full idea of what's really going on with this patient at the time. So these 6 rights of patient medication administration will also come back to haunt you in your national registry exam. You'll see it on our exams. You'll see it on our quizzes and things like that. Because this is one of the most important things is having these 6 rights of patient medication administration. And if you don't follow these, like I said, a patient can die. So in EMT, medications administration by the EMT. Units may carry oxygen, oral glucose, activated charcoal, aspirin, epinephrine. Here's some of the medications. We're also going to carry other things like New Hampshire. We have Tylenol, we have ibuprofen, we have liquid Tylenol as well. So there's other medications that are out there that the units may carry. So when you go to your ride time, ask your preceptor, hey, what medications do we carry that we can administer? And they're going to go over those with you as well. Some circumstances in which medications may be administered is a peer assist administration, patient assisted administration, EMT administered medications as well. So the peer assist would be like an AEMT saying, hey, can you help me with this? Or a medic saying, hey, can you give me a hand with this medication here? So again, we're not going to say, as me as a medic, I'm not going to say, hey, Nancy, can you go ahead and push this fentanyl for me? That's never going to happen. I'm never going to ask anybody to push a narcotic. But if it's something about like maybe giving aspirin or let's say even nitro, for example, that's a good one to administer. As a paramedic, I can administer nitroglycerin, so can an AEMT without medical control. I can say, well, you're trained to give this. I'd like you to give 1 nitro, please, while I'm trying to do other procedures. And that's something that you can utilize.
Is it us, if we are asked, is it best to say no?
If you are asked to push fentanyl, say no, I don't feel comfortable pushing it.
Okay.
Like if I ask you to push amiodarone or adenosine, those are medications that are intravenous that a paramedic should not be telling an EMT to push because you don't know how fast it has to go in or the right rate and things like that. So
I've never seen any of them. I was just curious. Like,
so
if
basically,
you're saying it must have happened at one point in
if
time.
you say, I don't know what that medication is, you probably shouldn't be giving it.
Very true.
These are determined by state and local protocols and medical control. So again, each state is different. And then obviously medical control also has the final determination. The state department and medical director will define which medications are carried on your ambulance. Some states are still MRH, which is medical resource hospital driven, and then some are not. So in New Hampshire, we're statewide protocol. In Maine, we're statewide protocol. So we have one medical director that says underneath the medical control board in each state saying you can do this. You can give these medications and put them on your ambulance. The MRHs still have the ability to say, well, we're not going to give you this med, we're going to give you this one instead. At the EMT level, there's really never going to be any difference. It's more towards the paramedic side of stuff, whether or not they give certain things out. So oral medications, the advantages, it's ease of access and comfort level as well. They're simple, they're easy to give. You just got to look to know how much you need to give based on your protocol. So Tylenol up to 1,000 milligrams. Well, they come in 500s. Here's 2 tablets. Ibuprofen comes in 200s. Max dose of 400. Here's 2 tablets. Aspirin, 81 milligrams per chewable tablet that we have. And we're going to give 4 to make 324 milligrams. So we give them 4 aspirin. We chew them up. Nitro is done in tablets as well. So those oral medications are very simple medications. The disadvantage to these, obviously, is the digestive tract can easily be affected by foods, stress, or illness. So if you give somebody aspirin and they vomit, it comes back up. What good has that done? So again, you got to look at your situation and treat it. Also, the speed of movement of food through the tract dramatically changes the speed of absorption as well. Confirm that the patient has a patent airway and is able to swallow, and then instruct the patient to chew or swallow the medication. All of our ambulances in Action Ambulance, we carry 2 bottles of water in the cabinets, and that's for patients to take Tylenol and ibuprofen. Aspirin is chewable, not swallowed as a whole pill. Activated charcoal. So as you can see here, these are charcoal capsules. We do not carry the capsules. We carry the actual liquid, which makes, by the way, one hell of a mess if you get it all over you. It literally is, it's charcoal. And what it does is it absorbs in the system. So this reduces the amount of medication being absorbed. So if this is given, it takes the medication that's in the stomach, absorbs it, and then it either pukes it out through vomit, or it's going to come out the other end through diarrhea, depending on it's sorbitol or not. It's ground into a fine powder for this situation, frequently suspended with sorbitol, like I mentioned before, administered by mouth. And usually, sometimes if they don't have if it's a liquid form, you give them a straw. I have tasted this before in my EMT class many years ago. They made us taste activated charcoal like on the tip of our finger, and it tasted like cornstarch. If the patient has an altered level of consciousness, we don't want to give it because it means they could not maintain their own airway. And as Charlie says to everybody, it's absolutely awful. Oral glucose is a sugar that cells use for energy. It needs to have glucose. This is what we use to treat hypoglycemia, so we need to check a blood sugar. Again, just because the blood sugar is at, like, say, 70, doesn't mean that we start giving oral glucose. Are they a known diabetic, non-diabetic? You also got to do more of an assessment. But again, oral glucose treats hypoglycemia. EMTs give it only by mouth. So what we do is we take the oral glucose, we put it into the corners of the mouth, not just drink it solid. We put it in more of the gums, and that's what they call buccal administration. And what happens is it absorbs down buccally down the esophagus and also through the gums as well. Do not give this to an unconscious patient or one who cannot protect their own airway because it is pretty viscous, it's pretty thick, and with that, the patient can actually occlude their airway with it. Aspirin reduces fever, pain, and inflammation. We're not giving it for fever. We're not giving it for inflammation. We're not giving it for pain. We're giving it for the platelet aggregation part of it. This is useful during heart attacks. So platelet aggregation, and people have this mindset that aspirin is a blood thinner. It is not a blood thinner. It is a platelet aggregator. And what's happening is it's taking your platelets in your body and it's making them less sticky to help makes platelets less sticky to help prevent any further clotting that's currently happening. So that's what aspirin actually does. So the contraindications would be hypersensitivity, which would be allergy to aspirin. If they have any liver damage, bleeding disorder, or asthma, it should not be given, because what will happen with asthmatics, at a rare occasion, it can actually trigger a significant asthma attack. To find somebody that has someone has liver damage, again, if the liver is starting to be turned bad, you're going to start seeing what they call jaundice or yellowing. So if you see that, we should avoid aspirin as well. And you should never give aspirin to children. So the days of causing it, or giving, my goodness, I'm having a moment here. The days of calling it baby aspirin are gone, because we don't want to have that mindset of giving aspirin to a child, right? Aspirin given to a child can cause something called Reyes syndrome, which is REYES, so Reyes syndrome, which is a rare but serious condition that causes confusion and swelling in the brain, and also can cause liver damage as well. So children also recovering from a viral infection such as chickenpox or the flu, or also have a metabolic disorder, are more at risk, especially if they've been taking aspirin. So again, we don't want to give aspirin to anybody under the age of 18. Sublingual medications, advantages, obviously easy to advise patients. And then quick absorption. So sublingual SL under the tongue, the only medication we'll be giving under the tongue like that will be nitroglycerin with assistance. Disadvantages, obviously, constant evaluation of the airway. You got to make sure that the airway is patent, and there's also potential for possible choking. Do not give anything sublingual under the tongue for uncooperative and or unconscious patients. So one of the medications we're going to be utilizing is sublingual medication would be nitroglycerin, which would release angina pain in cardiac patients, increases blood flow by vasodilating, and kind of relaxes the veins. The top bottle is a nitro spray. The drawback with spray is you don't know if you're going to get the full dose or not. It aerosolizes it, so it might get onto you. And it also costs about $300 a bottle. So ambulance services sometimes don't even buy these. The bottom one, the Nitro Quick that you see, is done in 0.4 milligrams, which the same thing would be for the spray as far as the administration goes. But our dosaging is going to be 0.4 milligrams sublingual under the tongue, and we give 1 tablet at a time, up to a total of 3 tablets. And that's ordered by medical control for EMT. These are a lot cheaper, and I want to say they cost like 50 cents or $1 a bottle. So 300 versus $1. So a lot of services go with the tablet form. That's all we carry. We don't carry the nitro spray. Before administering this, you want to make sure you check a blood pressure and obtain an order to administer. Here becomes the problem with nitroglycerin. We're giving it for the possibility of an MI if there's no relief. There may be a possibility there. And should not be used with erectile dysfunction medications, and also may cause a mild headache. That's going to be your side effect. The problem with giving nitroglycerin for patients having severe chest pain, if they are vomiting, it potentially could be what they call a right-sided MI, myocardial infarction, heart attack. If it's a right-sided MI and nitroglycerin is given to the patient, it will kill them. Patients that have that have what they call a preload issue, and they need fluid, IV therapy fluid. So again, for New Hampshire providers, before giving nitroglycerin, you want to make sure you obtain your 12 lead and transmit it to the hospital, or pass it off to a paramedic coming in that can interpret a 12 lead. At that point, we're going to call med control and say, hey, I just sent you a 12 lead. These are the patient's current vitals. I'm looking to get permission to give nitroglycerin sublingual under the tongue for a max of 3 doses, as long as systolic blood pressure stays above 120 systolic, whatever you want to utilize. He may say, nope, this is going to be a right-sided MI. I want you to withhold nitro and get this patient to the hospital and make sure you have a paramedic intercept en route. So that might be how it goes. But again, nitroglycerin, great medication, but has some side effects and or may not pertain to what you're giving it to. So again, just some things to be thinking about when you're administering meds. Administration by a tablet is sublingual under the tongue, no different than the spray under the tongue as well. 1 spray equals 1 tablet. The only difference is that you might have a slight tingling or burning sensation. And storage is also very important because nitroglycerin does not do well with sunlight. That's why they're in the dark bottles. Okay, so we don't leave them out in the open. We take it out of the bottle, administer underneath the tongue, they close the mouth, it dissolves, and hopefully it does what you're looking for the action. That's vasodilation and reduction of chest pain. Wait 5 minutes before repeating a dose. And same thing for EMTs. Anytime you give a nitro, before you give a second one, acquire another 12 lead for the EMTs for New Hampshire, because there may be something on that 12 lead that may change with nitroglycerin, because the patient could be getting better or be getting worse, and there might be some things on there, some what they call ectopy or other changes, where the patient's getting better, and we want to make sure we can see the trends. Monitor vital signs. Make sure you wear gloves with these, because remember, it can absorb through your skin. And know your local protocols. Intramuscular medications, advantage, quick, easy access without using a vein. And it's got stable blood flow to the muscles. That's how it works. Disadvantages would be the use of a needle or subsequent pain as well. So patients may fear pain or injury with this. We're going to be administering these medications intramuscular, so sticking a needle into their leg, and we're pushing medication through a syringe at the EMT level, or we're using an auto injector, which the needle is actually a lot bigger than what we're utilizing for the epinephrine IM injection through a syringe only. So there is some pain involved with this as well. So epinephrine controls the fight or flight response. This is what they call a sympathomimetic. Sympathomimetics are medications that stimulate the sympathetic nervous system, which we talked about during our human body, but it mimics the sympathetic nervous system, so epinephrine. The sympathetic nervous system has has neurotransmitters that are normal medications that are made in the body, and that's norepinephrine, which is created as a neurotransmitter. So with this happening, it kind of mimics that with epinephrine that causes a fight or flight response. So you're going to see them have, also called adrenaline, released inside the body under stress. You're going to see a tachycardia. You might see some hypertension and things like that. They might develop a headache. But the primary medication for delivery for this is going to be intramuscular. Hold on 1 second. Right, I'm back. So with the heart, with the epinephrine as well, it increases heart rate, constricts blood vessels. We do not want to give to patients with hypertension, hypothermia, having a heart attack. That'd be really bad. It says or wheezing. Now again, epinephrine, paramedic level, different world. But for what you guys are giving, though, we don't want to give it to patients that have a lot of wheezing, because it could be something with asthmatics. May be delivered with an auto injector to treat life-threatening anaphylaxis. That's what we're looking for. Not just an allergic reaction, but true anaphylaxis. When we get into environmental emergencies, we'll be covering this more in detail. Right. Allergens cause the body to over-release histamine. That's what I talked about, histamine receptors in the body, releasing histamine into the body itself, causing a full systemic reaction. Epinephrine acts as an antidote to reverse the effects of histamine. However, these patients still need Benadryl as a histamine blocker. So it helps reverse the effects, but the histamine still might be released after the epinephrine wears off. This is dispensed from an auto-injector, but in New Hampshire, in Massachusetts now, they're using what they call a ready check inject system. And I'm pretty sure Maine did the same thing. I'm 99% sure they did as well, where you have to draw it up, but you have to go through a special program to get this. Usually the services you get hired with will put you through it. Other intramuscular medications also used as intranasal as well as naloxone, which is Narcan, used to reverse the effects of an opioid overdose or opiate. Important considerations would be consult medical direction. Effects may not last long as opioids, repeated doses may be necessary. Because opioids are longer acting versus opiates, which are different. So fentanyl would be more of an opiate, but Suboxone would be more of an opioid. These can cause severe withdrawal symptoms as well, so you've got to consider safety. The point of Narcan is to not wake the patient up, but to get them transported to the hospital and keeping the respiratory drive enough so they can kind of maintain their own airway. If you wake patients up and you push too much Narcan too fast, it can cause them to wake up, they become flushed, they become very angry with you. They can also start vomiting and can lose their airway if they go back unconscious again. So it's meant to give in smaller doses. Unfortunately, with the preloaded intranasal, they're like 2, 4, sometimes they're 6 milligram setups, and that could be too much for a patient. So again, contact medical control. The most common technique for naloxone administration is via the intranasal route, as you can see here. And that white device that's inside their nose right there, that's called a MAD device, which we talked about earlier. And that helps with the nasal atomizer. It atomizes the air, or sorry, the fluid inside into the nose. And it's taken in through the mucous membranes into the body. It may not work instantaneously, but it works very quickly. So give it a minute or two. Keep using a BVM on the patient. Breathe for them. Eventually they'll wake up. Hopefully they'll wake up. That's the plan anyways. All right, inhalation medications like oxygen, all cells need it to survive. Remember, I mentioned before, the body needs 3 things to survive or else it will die. It needs oxygen, blood, and sugar. And remove any one of those 3, patient dies. Generally administered via a non-rebreathing mask, which is the preferred method, or nasal cannula in patients who cannot tolerate a mask. Now, when we get more into airway management stuff and things like that, we're going to talk about when we should be using non-rebreather masks versus nasal cannulas. MDI inhalers and nebulizers. What you're seeing here in the picture is what they call a nebulizer. It's a liquid turned into a mist or a spray. So if you can see my arrow on the screen, oxygen or medical air is coming through here. It goes into this chamber where there's a liquid inside of it. The air comes in, aerosolizes it up through the tube. And as they breathe in, it comes through the peace pipe side on this side here. As they exhale, it comes out the other end. So that's how this is utilized. Fast absorption rate, very easy route to access, and it's very portable as well. And just to kind of throw out there, and this is not me telling you guys to ever do this, I've been on calls before where people have had these nebulizers at home, and they have put vodka inside of these things and nebulized it into their system, and you get drunk very, very fast with these. So I'm not saying try it. Please do not try that at home. But if you come into a contact with it, remember aerosolized alcohol now, so you got to be careful.
Evan, really quick.
Yeah.
With that, really. So if you had somebody in the back of the ambulance and had stunk it up, we've done it before, is Listerine, put Listerine in them and let that go in the back, and it kind of takes the stench out of the ambulance too. Just another thing to do with it.
But we gotta keep this in mind. This is not something we're going to be doing for medication administration. But if it gets rid of the smell, hey, whatever works. Yeah. Smell in a truck.
That's another tool with that nebulizer.
Yeah, it does work pretty well. Just keep in mind that that's not what we're giving to a patient though. But yeah, thanks, Aaron.
No.
Anything to get rid of smells in the back of the truck, and you guys will see some weird smells over your time in your career as an EMT. So I mentioned before about a spacer with an MDI, which is this device here. So it fits over the inhaler like a sleeve, and what happens is the patient sprays the prescribed dose into the chamber, and then breathes in and out of the mouthpiece itself. This helps prevent loss of medication. So the way an MDI inhaler works, and especially works really well for young children, is we shake it up, apply the spacer. If there isn't a spacer, it goes into the patient's mouth. On the inhalation, we're going to squeeze the device and push the medication in. You want to advise them to hold their breath for 10 seconds at the best they possibly can, and then exhale. That allows for the medication to get deep into the alveoli to help bronchodilate, not only the bronchioles, but the alveoli and everything to open up. It gets deep in the bronchioles to allow for better gas exchange. Because with asthmatics, there's a lot of mucus buildup down inside. And what's happening is it's preventing any air from coming in. So we want to make sure we open those airways up, and this is how we can do it. But they have to hold their breath for a longer period of time to let the medication actually work. So small volume nebulizers, as you can see here, which you might be assisting with, are easier to use than MDI, but take longer to deliver the medication. Requires an external air or oxygen source. They're more effective in patients with moderate or severe respiratory distress, and it can be utilized or used while the patient is on CPAP or during BVM ventilation. So there's other devices we can utilize with the CPAP to do what they call inline nebulization. And I can show you guys that when we do our airway practical days and how that works. Rescue inhalers, MDIs, to relieve bronchial spasms quickly, but again, it doesn't stay there. If patients are having what they call status asthmaticus or severe asthma attack, they still might need other treatments like nebulizers, albuterol, or what they call a duoneb with a steroid, which has ipratropium bromide in it. But they're also going to need other steroids like Decadron or Solumedrol or things like that to help open up their airway. Paramedics carry a wide variety of airway medications to include magnesium sulfate and other things as well. So if your patient's not getting any better quickly with the quick treatments that you have at the EMT level, get a paramedic started right away so they can help open this patient's airway up even better. The only medication that is effective during an acute attack of shortness of breath is a fast-acting rescue inhaler, because it puts out a metered dose as you inhale it, and it works quickly, but again, doesn't always last, so you might need to have the extra help. Patient assessment also includes finding out what medications the patients are actually taking. And on your sample history, that would be the M, which provides a vital clue to the patient's conditions. It also helps guide its treatment, and also will be useful to the emergency department by obtaining a medication list. The reason why I say it provides clues, if a patient goes, I don't know, the doctor just told me to take this, and you see Lasix on there. Well, we know Lasix is a water pill. Well, I'm on this water pill. I'm not sure what it does. Well, Lasix is a diuretic. We know that. It's also non-potassium sparing, which means that if a patient's on Lasix pills, they're peeing out their potassium and they really can't replenish it, which can then cause chest pain. The whole thing goes on and on. These are all things you'll pick up over time on assessments. But if I see Lasix on there, I know that he has edema. He might have right-sided heart failure. That helps me with my medications. If I see something that says metoprolol or anything that ends in OLOL, I would consider that as a beta blocker, and I would see patients that have high blood pressure on beta blockers. And that also may cause them to have low heart rates, which is also one of the side effects of taking beta blockers. So again, I'm throwing a lot of things at you right now, but these are all important things to find that provide vital clues to the patient's condition. So looking at that kind of stuff. There's nothing wrong with putting Hippocrates on your cell phone and looking up a medication if you don't know what it is, right? Because that may be the clue that you need to help treat this patient. Medication errors. Inappropriate use of a medication that could lead to a potential harm. It may also be possible to minimize errors if circumstances are understood. Ensure the environment does not contribute to the errors that are there. And if you make a medication error, please do not lie about it. Do not disregard yourself giving it. And you have to document that a medication was given an error or maybe the wrong route. It doesn't mean that you're going to lose your EMS license. It doesn't mean that you're going to get in a lot of trouble. But there may be some remedial training coming down the road in that aspect of it. And that's me speaking as a clinical supervisor. That's what I would do, depending on what medication was administered and what happened to the patient. If a medication error occurs, provide appropriate patient care, notify medical control, and follow your local protocols. You're going to document them thoroughly, accurately, and honestly, and you're going to talk to your partner about it, your supervisor, and or the medical director, all right, to get through it. All right, so any questions with pharmacology? Did I hit a lot of good topics for you guys in that?
Yeah.
All right, I didn't go too in depth on you.
Seems like a more nerve-wracking one.
There's a lot. So, and one of the things I didn't mention, which I'll throw in right now. So if you guys want to write some of these down, anything that ends in a statin or statin, so statins are used for cholesterol treatments most of the time. All right, so simvastatin, things like that would be used for cholesterol treatments, or I'm trying to think of the other name for it. Anything that ends in PRIL, like lisinopril, those are called ACE inhibitors. So ACE inhibitors. ACE inhibitors are used for blood pressure treatments. But the interesting thing about ACE inhibitors, and it's also, ACE stands for angiotensin converting enzyme. You don't need to know that at all unless you want to look it up. It gets way more in depth into the human body and how things work. More into the cellular structure, like AMP1. So, but prils, like lisinopril, people can have weird reactions to that, even though they've been on it for like 5 years. And one of the common reactions to that is what they call angioedema, or swollen tongue. So they come in and they're like, oh, my tongue just started swelling up. And you ask them, well, you on lisinopril or any kind of ACE inhibitor? They go, yeah, I've been taking that for 4 years. That could be your culprit right there. The other one is OLOLs. Anything that ends in OLOL are beta blockers. Those can have a big effect on heart rate and actually drop your heart rates down a lot too. So you may see like an elderly person who's, let's say they have syncopal episodes, their heart rate's in the 50s, they keep passing out. Are you on beta blockers? They say, yeah, my doctor just changed my dose from 25 to 50 milligrams. Well, that could be the problem right there. So let's stop the beta blockers and let's bring them to the hospital and get your meds readjusted. Right? So there's a lot of things with pharmacology, and I like pharmacology, by the way, if you haven't picked up on it. But the good thing about pharmacology, it really helps you tailor your assessment. And also, the patients that are unconscious and you have no idea what's wrong with them, you look at their medication list and they go, oh, well, they're on beta blockers or on ACE inhibitors. I see diabetic medications on here. We should probably check a blood sugar. Oh, it's 40? Great, we need to load and go. We need to get a paramedic here to give D10. So there's a lot of things with pharmacology that help play into this. Right? So that's kind of my spiel on pharmacology, and you're going to hear more of this as we get into specific treatments, like we talk about cardiology and chest pain and stuff like that. We're going to be discussing more about aspirin, more about nitro, and we'll get into more in detail on those and how we administer them. All right, so pharmacology is defined as the what?
B.
B.
I'm trying to bring up the chat box so I can see this as well. Oh, I hit that a little too fast. Yeah, the answer is B. Number 2, which of the following statements regarding medications is false?
See?
I'm seeing some C's come up.
See.
The answer is C. Over-the-counter drugs, OTC drugs, such as aspirin, Tylenol, and Motrin, do not require a physician prescription. They can be purchased at a supermarket or drugstore. Most medications have a generic name and a trade name. For example, acetaminophen is the generic name for Tylenol, and ibuprofen is the generic name for Motrin.
Tremendous amount of resistance to the air moving through it.
Which of the following routes of medication administration has the fastest effect?
B.
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 A lot of B.
B.
Let's go with B. Good answer. Number 4, when administered to a patient, a meter dose inhaler will do what?
A.
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 A it is. All right, so number 5, you are managing a 62-year-old woman who is complaining of crushing chest pain. Her blood pressure is 84/64, and her heart rate is 110. MedControl advises you to assist her in taking her prescribed nitroglycerin. After receiving this order, you should do what? What did I mention about nitro and what it does to the body? What's its action?
Lowers your blood pressure, B.
Right. I see B. I see B
B.
on text.
One way to mitigate the risk.
All right. The answer is B. Remember that nitroglycerin is a vasodilator and lowers blood pressure. Therefore, it should not be given to patients with a systolic blood pressure of less than 100 milligrams of mercury, which is your systolic number. If you have a top number on the blood pressure, if you have received an order to nitroglycerin to a patient that has a systolic BP of less than 100, you should ensure that the physician is aware of the patient's blood pressure, then reconfirm the order. Just because the physician tells you to do something does not mean it's correct. He may have missed something, or when you told him that it was 84, he could have thought you said 184. So again, repeat it and let him know. Right? Remember, physicians don't always know the scope of practice for EMTs, even to paramedics. It may ask you to do something that's not within your scope of practice. Number 6, activated charcoal is indicated for patients who have ingested certain drugs and toxins because it does what?
D.
Right? I'm seeing D. I hear D. I see D. All right, D it is. Remember, it's an absorbent. Right? So that is, it binds to harmful chemicals that they have been ingested. Again, check with MedControl because you may not want these things to come back up. So something else to make of this as well is if you're giving a patient activated charcoal for a chemical ingestion and it's a caustic chemical, the last thing you want is for it to come back up through your airway and burn your esophagus a second time. So again, talk to MedControl before administering activated charcoal because it may be contraindicated based on what kind of chemicals in the body. Number 7, with regard to pharmacology, the term action refers to
C.
D.
D. So the solution is
the answer is going to be D. Remember that action is what it does to the body, what are the effects that it does. Oh, number 8 is A. Sorry. But this is the question anyways. Which of the following patients is the best candidate for oral glucose? Hypoglycemia. Number 9. Epinephrine is given to patients with anaphylactic shock because of the effects of what?
style. A. Particularly in the way they keep all the finest.
I see A on the text box. I heard A.
A.
The answer is B. The two major complications associated with anaphylactic shock are bronchoconstriction, which impairs air movement in and out of the lungs, and vasodilation, which causes a drop in blood pressure. Epinephrine reverses the process by causing bronchodilation and vasoconstriction, so it reverses them, causing the airways to open up more, and it causes the vessels, the vasculature, to close to allow for an open airway and your blood pressure to come out of that shock state. Right, therefore, by improving breathing and increasing the blood pressure, respectively. All right, number 10. So the process by which the medication travels through the body tissue until they reach the bloodstream is called what?
C.
C.
All right, C it is.
C.
All right, so we've been at this now for about an hour and 20 minutes. So why don't we take a 5-minute break? Well, let's say take 10 minutes. We'll come back, finish up chapter 12, and we'll be done for the night. So I'll see you guys around 7:33.
Okay. Units are good for collecting the tips.
Hello?
All right, is everybody back?
Yeah, I'm here.
Yep.
Perfect.
I'm back.
All right, so we'll get through this lecture here and we'll be done for the night. So this lecture, we're going to talk about shock. There are many different forms of shocks, types of shocks, and we're going to go through all of those during this lecture. So obviously, shock and resuscitation applies to the fundamental knowledge of the cause, pathophysiology, and management of shock, respiratory failure or arrest, cardiac arrest or cardiac failure or arrest, or post-resuscitation management. So it's all different types of shock and resuscitation we're going to go through. The pathophysiology behind it applies fundamental knowledge of the pathophysiology of respiration and perfusion. So kind of going back to the human body stuff that we talked about, to the patient assessment and management. So shock, which is hypoperfusion, describes a state of collapse and failure of the cardiovascular systems, otherwise known as an inadequate state of tissue perfusion. In the early stages, the body attempts to maintain what they call homeostasis. Homeostasis is like us on an even playing ground, because everything's all the same. Any deviation of homeostasis causes problems, and we'll talk about that in a little bit. As shock progresses, blood circulation slows down and eventually ceases. And we'll talk more about shock and how it protects the vital organs when we start talking about shunting of blood. We get into that. Shock can also occur because of a medical or traumatic event, whether it be a heart attack, severe allergic reaction, motor vehicle crash, gunshot wounds, and other things like that. EMTs respond to different types of emergencies to provide care and transportation, but they must constantly be alert for the signs and symptoms of shock, which is why we need to make sure we're monitoring vital signs on our unstable patients every 5 minutes so we can pick up on that, on any types of shock type symptoms. So pathophysiology behind it. So perfusion is the circulation of an adequate amount of blood to meet the cell's current needs. So remember, the body is perfused via the circulatory system, right? Perfused with oxygen and whatnot as well to maintain the cells. So organs, tissues, and cells must have adequate oxygenation or they may die. In order for oxygen to be transported, we have to have good blood circulation. And good blood circulation would be having the ability of having like platelets and hemoglobin, all that stuff within the blood system to transport this oxygen to the cells and then take the bad stuff, the waste, and bring that back to the lungs to be able to output as carbon dioxide. All right, so that's how we're going to be perfusing our organs and our tissues. Air goes in, blood goes round and round, air comes back out. And then utilizing other filtration systems that we have within the system. So in cases of poor perfusion or shock, transportation of carbon dioxide of the tissues is impaired, resulting in a dangerous buildup of waste products which may cause cellular damage. And we'll talk about crush injuries and shock later on. Shock refers to a state of collapse and failure of the cardiovascular system that leads to inadequate circulation. So with shock as an unseen life threat caused by a medical disorder or traumatic injury. If the conditions causing shock are not promptly addressed, death may occur soon. So we have 3 different stages of shock. We have what they call compensated shock, then we have decompensated shock, and we have irreversible shock. And I'm sure you all know what irreversible means. It cannot be fixed, which means they're going to die at that point. Cardiovascular system consists of 3 parts. You have to have a pump, which is the heart, a set of pipes, which are blood vessels or arteries, and you have to have the contents, which is blood, to be able to work. So for the firefighters in the room, in the classroom, the pump, the fire pump is the heart. The pipes, blood vessels, and arteries would be like your large diameter hose and your 1.5 inch, 1 3/4 lines, right? Vessels, arteries, and your contents of blood would be the water. So you kind of can correlate the difference. If you guys in the room, any of you guys have pump operations training, pumps 1, pumps 2, whatever that may be, you'll have an understanding that the heart is very similar to a fire pump and how it works, as you can see here. So looking at the system, remember we take air in, so air comes into the system, right? We breathe in. It comes in through our trachea, down into our lungs, through our bronchi to the bronchioles, the alveoli. Blood is coming through into our pump. So our pump's pumping in. It takes the oxygenated blood and then drops off the deoxygenated blood. So think of like a dump truck dropping off a load and picking up a new load. So it picks up the new load of oxygen, dumps off the waste load of carbon dioxide, goes into the heart. Remember, it starts with the right atrium, goes into the right ventricle, goes through the lungs, okay? In the lungs, they pick up the good stuff, the oxygen. It goes through the left atria to the left ventricle, pumps through the body. It goes through our capillary beds. Gas exchange is happening. The good stuff gets dropped off. The bad stuff gets picked up, comes back through to the superior and inferior vena cava, back into the right atrium, into the right ventricle, into the lungs, and then it exchanges it back over again, picks up the new stuff. That's kind of the way the drop of blood works in a very simple version. So again, it's no different than a fire pump. Water comes in, water comes back out, and it gets circulated through. So there are three parts that can be referred to as the perfusion triangle, right? So when a patient is in shock, one or more of the three parts is not properly working. Again, fire terminology. You get the fire triangle, right? Fuel, heat, and oxygen. You have to have vessels for container function, blood to content function, and a heart for pump function. The triangle, same thing, right? So damage to the heart by disease or injury decreases the ability of the heart to properly function as a pump. Therefore, it cannot move enough blood through the body to support the perfusion. The pump doesn't work, it fails. That's what we call cardiogenic shock. The heart is failing. Blood vessels, container function. If all blood vessels dilate rapidly, the normal amount of blood volume is not enough to fill the system to provide adequate perfusion to the body. That would be our distributive shock. So think of distributive, and again, I like to use fire terminology here. You know how we have concentrated loads and distributive loads based upon weight on a roof or whatnot? It's the same thing here, distributive throughout the entire body. So looking at that, septic shock, which we have bacteremia, bacteria going through the blood system causing rapid dilation. The same thing happens with anaphylactic shock when you have rapid dilation causing hypotension. And we need to fix that by giving medications, epinephrine being one of them to help with that. Or in the paramedic world, what they call norepinephrine or levophed would be utilized for the septic shock, also along with more fluid, right? So the pump is going to eventually fail if you don't have the blood coming in. But obviously, content, right? If there's not enough blood or plasma, the volume of liquid in the container is not enough to support the perfusion needs to the body, eventually your blood runs out. It's kind of like cavitation of a fire pump, the same thing. Your pump cavitates if you don't have enough fluid going in. So you got to have fluids. You got to be able to feed your lines, right? So again, you can take that analogy all you want. The firefighters look at a fire pump and how it works. For the people that are strictly EMS and have a better medical background, look at it as the heart pump function using the perfusion triangle. It's all the same stuff. It's just in different parts, right? So the blood pressure is the pressure of within the vessels at any moment in time, whether it be systolic or diastolic. So the systolic, it's the peak arterial pressure. That means the pressure in motion, pressure against the walls. Your diastolic pressure is pressure in the arteries while the heart rests between heartbeats, right? So if we have a blood pressure of 120 over 80, that's a perfect blood pressure. 110 over 70, even better. That's what we're looking at, right? We start getting blood pressures in our stroke patients, our heart attack patients, things like that. We're seeing 200 over 110, 240 over 150, things like that. The arteries don't have, they're being overpressured. They don't have a chance to even rest because they're still at a very high pressure even at rest. And this is what's happening with this stuff here. So in shock forms, though, we're seeing low pressures because our vessel is so dilated that we have no more pump left to fill the pump. Pulse pressure is the difference between the systolic and diastolic pressures. So pulse pressure signifies the amount of force the heart generates with each contraction. A pulse pressure less than 25 may be seen in patients within shock. Another thing that we look for also for shock is what they call an MAP, M-A-P, which is called your mean arterial pressure. And anything below 64 would be considered sepsis. And the lower it goes, the worse off the pump actually is because of the massive widespread vasodilation. So blood flow through the capillary beds is regulated by the capillary sphincters. So under the control of the autonomic nervous system, capillary sphincters respond to other stimuli, heat, cold, and the need for oxygen and waste removal. Perfusion works more than just having a working cardiovascular system. You have to have adequate oxygen exchange in the lungs. That's why getting patients on oxygen is key in patients that are in shock. Non-rebreather, 15 liters a minute. Adequate nutrients in the form of glucose in the blood. You have to have sugars. Sometimes patients that are in shock may have low sugar levels. Adequate waste removal, primarily through the lungs. Can the patient adequately dispel carbon dioxide? And if they're not breathing appropriately, or they're breathing too fast, or they're breathing too slow, it'll make them acidotic or alkalotic, and we're not meeting that homeostasis, that even playing ground that we need to be on. So this is where ventilation with high flow oxygen works in using a VVM. So mechanisms are in place to help support the respiratory and cardiovascular system when the need for perfusion of vital organs is increased. So mechanisms include the autonomic nervous system and hormones. So one of the things we're going to see with other support systems is what they call, in shock, shunting of blood. So when your body gets to the point where it can no longer maintain, it starts shunting extremities and organs to keep the heart alive. So its main purpose behind the heart and the brain is in making sure that stuff stays alive. So what you're going to see is you're going to see shunting of blood. So you're not going to have good blood flow to the arms, to the extremities, the lower legs, and the legs itself. And then if you've ever noticed a patient that's in shock, one of the first symptoms they may complain of is nausea, because the first organ to start shutting down is going to be your stomach. So that's why when the AEMTs and paramedics are there, like, oh, we're just going to give some Zofran for the nausea. Well, if it's shock, Zofran or ondansetron is not going to fix the nausea, so an antiemetic's not really going to work. What they need is fluids and the blood pressure to come back up so that stomach stops shutting down. Because the body figures the stomach is one of the most least important body parts or organs in the system that can keep running in a patient who's in shock, because you can survive without the stomach for a certain amount of time. So the stomach starts shutting down first and other organs will follow. Hormones are triggered when the body senses pressure falling. So what will happen with these hormones being triggered and start releasing is you'll start seeing an increase in heart rate and a strength of cardiac contractions. So you'll see the heart rate going up, you'll see a more bounding heart rate, and you'll see peripheral vasoconstriction. And that's what I was talking about, the shunting of the blood. So your heart rate goes up, your cardiac contractions get stronger, and your peripheral vasoconstriction to your extremities starts shutting down to keep the core alive. Together, these actions are designed to maintain pressure in the system, to make sure it sustains perfusion to all the vital organs. And it is the response that causes all the signs and symptoms of shock. So it's this response that's happening. So understanding how shock works will help you determine, oh, this patient needs IV therapy. We need to get at least an advanced EMT on board for this. Or, my goodness, the patient is in severe hypotension. We're going to try to elevate their legs a little bit, put them in like a Trendelenburg position to keep the blood flow to the core. We're going to warm them up so they helps oxygen transport by putting blankets on them, put them on non-rebreather oxygen to vitals every 5 minutes, get the paramedic on board so they can start other medications that are needed. Shock can also result from bleeding, respiratory failure, acute allergic reactions, and overwhelming infection. So that would be respiratory failure, as you can see, is pretty self-explanatory. Bleeding internally or externally, anaphylactic, overwhelming infection would be sepsis. Damage occurs because of insufficient perfusion to organs and tissues. And we kind of already went over this, the causes of shock already. So poor vessel function, infection, drug overdose, narcotics, spinal cord injuries, anaphylaxis. It shuts down the distributed type shock. It shuts down the system. Low fluid volume will be caused by trauma, fluid loss from GI tracts, so vomiting, diarrhea. Can also lower the fluid component of blood as well. So obviously GI bleeds. So if they're crapping out blood, vomiting blood, esophageal varices is another one. You can have significant fluid volume loss of blood. And obviously pump failure, cardiogenic shock, where you'll see the heart attacks, trauma to the heart, anything that does something to the heart itself, which causes or a large pulmonary embolus. We have a clot in the lungs that stops complete blood flow to the heart as well, and oxygenation. So pump failure, cardiogenic shock, which we talked about, or another known would be obstructive shock, so tension pneumothorax. So a pneumothorax is the collapsed lung. Tension is under some form of trauma or some sort of support that caused it to happen. Cardiac tamponade is another one, and then pulmonary embolus. When we get into cardiac emergencies, we'll teach you how to actually assess and look for cardiac tamponade. It's what they call Beck's triad, and you guys can look it up if you want to right now, but we're going to cover it later on. Distributive shock would be your neurogenic, anaphylactic, psychogenic shocks, and septic shocks. And hypovolemic shock would be your hemorrhagic or non-hemorrhagic shocks. So obviously hemorrhagic being bleeding, or hypovolemia through like massive vomiting and things like that can cause them to be a non-hemorrhagic type shock. These three things you're going to see on your national test. You're going to see them on my exams. You're going to see them on quizzes. This is very important stuff at the EMT level to be picking up in the field. Cardiogenic shock is caused by inadequate function of the heart. So the major effect is the backup of blood into the lungs. Right? At this point in time, your pump is starting to fail. Resulting in buildup of pulmonary fluids is called pulmonary edema, otherwise known as APE, acute pulmonary edema. You'll see this with patients that have left-sided heart failure because the heart is no longer pumping on the left side effectively due to a cardiomyopathy of some sort or a floppy heart, and therefore is storing blood or cannot pump blood effectively, backs up into the left atria, into the lungs. Right? And this is where you start seeing fluid, and you'll probably start seeing what they call pink frothy sputum. So if you get to that point, suctioning, BVM, definite airway management.
Kevin,
Yeah.
so to take the fire engine analogy, the supply is still coming, but the pump itself can't keep, pushing out the same effect that the supply is coming in.
Exactly. So you got supply coming in, being forced in. So let's put it into a fire analogy, pressurized hydrant, or having someone doing inline pumping from a hydrant to a truck, or from a hydrant, like dry hydrant or whatever, to a truck that way, through supply functions that way. Yes, fluids are still coming in, and it has nowhere else to go. So you ever notice that when you're putting too much water to a fire truck, it comes out somewhere, right? Usually it leaks out through the tank, tanks overflowed, or whatever it may be.
Yeah, relief valve.
Yep. That's also happening here, but it's relieving itself into the lungs, causing complete flooding of the lungs itself for acute pulmonary edema.
Makes sense, yeah.
Yep. It's amazing what you can do with a fire pump and put it into heart functions. It's crazy. So cardiogenic shock edema is present over the is the presence of abnormally large amounts of fluid between the cells and body tissue causing swelling, as you can see here. The normal side versus fluid on the left-hand side for pulmonary edema, and eventually all this is filling up, and eventually it comes up through the through the alveoli to the bronchioles, to the bronchi, to the main bronchus going up, and then next thing you know, you start seeing pink frothy sputum because there's nowhere else for it to go. If you have a patient that's in cardiogenic shock or pulmonary edema and you pick up on it early enough, as an EMT, we do something, well, now you can do CPAP. But in Maine, you don't have CPAP yet at the EMT level. So you're going to do something called, I like to call it poor man CPAP. Have the patient in a sitting up position, put a BVM over their face, And every time they take a breath in, you're going to push air in with it. And what you're trying to do is take that fluid that's in the lungs and you're trying to push it back out into the system. And that's what CPAP is doing. It's causing, because CPAP works really well with this as well, by providing continuous positive airway pressure, utilizing positive and expiratory pressure. So going back to what we were talking about with respiratory stuff before, if you take a deep breath right now, everybody take a deep breath, in and out, leave your mouth wide open. The air comes out really fast. But if you purse your lips and do a kissing type lip position and try blowing out that way, it keeps your lungs open for a longer period of time. That is what they call PEEP. It's positive end expiratory pressure. Right? Does that make sense for CPAP? You guys? All right.
Yeah.
Yes.
All right. So pulmonary edema leads to impaired respirations, which can be manifested by an increased respiratory rate or abnormal lung sounds. You're going to hear crackling, popping. It's what they call rales. You're going to hear fluids in the lungs. And these patients that have had it before, you can say, "Do you feel like you're drowning?" They're going to say yes, because you're going to hear gurgling sounds and things like that. And you might hear that as an audible sound, not even putting a stethoscope to the lungs, just to hear that gurgling type sound. That's the rales that's coming up. It's building up a fluid, and you're going to hear it on both sides. It'll be bilateral pulmonary edema. Cardiogenic shock also develops when the heart cannot maintain sufficient output to meet the demands of the body as well. So again, if there's a major bleed, it can't keep up. And eventually you can go into cardiogenic shock, but usually you'll be hypovolemic first. Obstructive shock is caused by a mechanical obstruction that prevents an adequate volume of blood from filling the heart's chamber. The three most common examples will be pulmonary embolus, tension pneumothorax, and cardiac tamponade. So to kind of look at pulmonary embolus, a lot of times with a patient with pulmonary embolus, you'll see patients that have like significant chest pain. They're going to potentially see like anxiety as well. And you also see decreased SpO2. Tension pneumothorax, you're going to take a listen to lung sounds. And with tension pneumothorax, you're going to hear absent lung sounds or diminished lung sounds on one side. A lot of times sometimes you can have what they call a spontaneous pneumothorax. And a lot of times you'll see those in your tall, white males, skinny, tall white males. You'll see that as a spontaneous pneumo. Tension pneumo is under any kind of like trauma. So if you have a patient, let's say in a motor vehicle accident, they smash off a steering wheel in their chest, that can cause a tension pneumothorax. But that can also cause what they call a cardiac tamponade. So Beck's triad is a collection of three clinical signs associated with a pericardial tamponade, which is due to excessive accumulation of fluid within the pericardial sac of the heart. The three signs you're going to see is hypotension. You may want to write these down because you'll probably see them again. Hypotension, muffled heart sounds, and weak or narrow pulse pressures. So pulse pressures are your blood pressure, systolic and diastolic, being very close in number. So you might see a blood pressure of 90/86. So very, very close, narrowing pulse pressures, blood pressures like that. You're going to see muffled heart tones, because remember, that's not pumping effectively, and they're muffled because now you have fluids around the pericardial sac, all right? And you'll see hypotension with that as well. So that's Beck's triad. All right, that's what I wanted to talk to you guys about a little bit today when you're doing your assessments. So if you see those three things, Beck's triad, cardiac tamponade, what this patient needs is an OR, because it needs something called the pericardial centesis, and they take a big needle, go through the skin of the chest, into the heart, into the pericardial sac, and they pull the fluid out through a syringe. That's what they call a pericardial centesis. So that's what's happening with cardiac tamponade. So Beck's triad, which is an EMT skill to be able to pick up on, is something you might see later on down the road. And I can almost guarantee you'll see that on your cardiology part of your exam on your national. So cardiac tamponade, they mentioned Beck's triad here at the bottom, is a collection of fluid between the pericardial sac and the myocardium, which is called a pericardial effusion, becomes large enough to prevent ventricles from filling with blood, caused by blunt or penetrating trauma. So you could have, something going through penetrating wise, or significant blunt trauma, motor vehicle accident, anything with a chest wall that involves that. And signs and symptoms are referred to as the Beck's triad, which we just covered. Tension pneumothorax caused by damage to the lung tissue, as the air normally held within the lung escapes through the chest cavity itself, causing the lung to collapse, and the air applies pressure to the organs, including the heart and the great vessels. So when your lung collapses, remember your lungs run on a negative pressure system, so now air comes in, causing the lung to collapse, all right? Causing pressure on the heart, which then can cause the heart not to pump effectively, so hypotension. You might see what they call a tracheal deviation, so your trachea pulls to the side of lungs that are working, so be opposite that, opposite lung sounds as well. So these patients here need a paramedic right away because they're going to need what they call a needle decompression. And they put a needle into the chest to relieve the air that's in there to allow for the negative system to work again, to keep the lungs open. And eventually they're going to get a chest tube at the ER or in the OR. Pulmonary embolus is a blood clot that blocks the flow of the blood to the pulmonary vessels. If massive, can result in complete backup of blood to the right ventricle, leading to catastrophic obstructive shock and complete pump failure, which will put you into cardiac arrest. A lot of times with patients like this, you'll see them in cardiac arrest if they are, and they'll be like, so those of you guys that do fire again, they do investigation stuff, there's something called the line of demarcation, where you can see where it burns and isn't burned. You see that line where the fire actually moved above. Same thing when you talk about pulmonary embolus on a patient in cardiac arrest. You'll see like a line, like across the nipple line, and there'll be like a black, dark black above, and below will still be pink. You can actually see what the embolus kind of is and where it stopped blood flow. Distributive shock results in widespread dilation of small arterioles and small venules, or both. The circulating blood volumes pool in the expanded vascular beds, and the tissue perfusion decreases. Let's get a little more into this. Septic shock and sepsis is one of my big things. I'm actually doing a sepsis lecture tomorrow at 9 o'clock through GoToMeeting for the Action Ambulance as a company. So I'm doing a full sepsis lecture on that. But it occurs when, as a result of severe infections in which the toxins are generated by bacteria or by infected body tissue. What's happening is the infection, whether it be pneumonia, it could be UTI, it could be anything that involves an infection that gets into the bloodstream. And that's what causes bacteremia. Remember, uremia being the blood, and bacteria, bacter would be bacteria getting into that, causing a wide systemic reaction called septic shock. What's happening is your toxins then damage the vessel walls, causing increased cellular permeability. By doing so, we're now flooding the system. And vessel walls start to leak and are able to contract well, and therefore causing severe hypotension. You'll see tachycardia. You'll see a decrease in end tidal, lower than 32, increased heart rate of greater than 90. You'll see a MAP, mean arterial blood pressure, of less than 64. The patients most likely will have a fever of greater than 100.4, or they could be what they call cold sepsis, which would be less than 96.4. Either way, those are both very bad. So you'll see a lot of those different things that are indicators of sepsis that could turn into a septic shock type deal. Patients that are in septic shock most likely are going to be intubated with an ET tube, put on a ventilator, and they're going to be given pressors to help keep their blood pressures up. But normally this is treated with large amounts of IV fluid, and I'm talking 5 to 6 liters of fluid. So if you have patients in septic shock, you need ALS on board to start giving these fluids to these patients, because fluids are what's going to save their lives. If anything else, it's going to be fluid because they're becoming basically internally dehydrated. Widespread dilation of vessels in combination of plasma loss through the vessel walls result in shock. Neurogenic shock, usually the result of a high spinal cord injury. Causes include brain conditions, tumors, pressure on the spinal cord, or spina bifida. So there's different things that it could cause. So neurogenic shock, as you can see here, or distributive, you can have a spinal cord damage, and if this happens, you get spinal shock causing dilated vessels. So you can see a normal vessel up here in the picture. Below that is your dilated vessel. So what's happening is you have absence of sweating, loss of body temperature control, because you've lost your spinal cord functions. So muscles in the blood vessel walls are then cut off from the nerve impulses that cause them to contract. So now you have widespread vasodilation, causing blood pressure to drop significantly. The patient needs fluids. Anaphylactic shock, also another form of distributive shock, occurs when a person reacts violently to a substance for which he or she has been sensitized. Sensitization means becoming sensitive to a substance that did not initially cause a reaction. So strawberries is one of them, or seafood. Patients that have eaten seafood all their lives, or strawberries all their lives, and all of a sudden have a bad reaction to it, because now you're no longer desensitized to it. Each subsequent exposure then tends to produce a more severe reaction. Eventually, it'll be to the point where if they eat something, they become so allergic to them, they become anaphylactic, to the point where they have widespread vasodilation and they end up dying from it. The dangerous part about anaphylaxis is angioedema, or swelling of the tongue to the point where it completely occludes their airway. And there's nothing to do to reduce that right away. Even if you give Benadryl and Epi, it's still not going to reduce it. There are 4 categories of exposure. One would be injections. Second one would be stings, ingestion, or inhalation. As you can see, all the different things that are listed on there. A big one that we come in contact with, obviously, are shellfish and nuts. This develops within minutes or even seconds of contact with a substance. The second phase reaction can occur 1 to 8 hours after initial reaction. Signs are very distinct in any kind of distributive shock, and cyanosis, or blue discoloration of the skin, is a very late sign, which means they've been hypoxic for a little while. Any patient that has an allergic reaction or close to anaphylaxis, one of the questions you want to ask them is, have you ever been intubated for this before? And if they say yes, we know that it's a severe case. Some signs and symptoms of anaphylactic shock obviously are flush, itchy, and burning sensation, urticaria, which is also called hives, edema in the face, tongue, and lips, pallor, cyanosis. That's part of your skin. Your circulatory system would have dilated peripheral blood vessels, increased vessel permeability, drop in blood pressure, weak or barely palpable pulses, respiratory system, stridor, upper airway obstruction, sneezing, tightness in the chest, wheezing, dyspnea, difficulty breathing, secretions of fluid and mucus into the bronchial passages and the alveoli, causing coughing and lung tissue issues, constriction of the bronchi, forced expiration, cessation of breathing, abdominal cramping, nausea, vomiting, altered mental status, dizziness, fainting, and coma. All things that can happen with anaphylactic shock. Psychogenic shock is caused by a sudden reaction of the nervous system, which produces temporary generalized vascular dilation, results in fainting, or what they call syncope. Some causes are serious and some others are not. Some ways to help with this also is checking what they call orthostatic pressures. So you take a blood pressure with a person lying down, sitting, and then standing, usually waiting within a minute apart of each other after they stand up, taking a blood pressure to see if there's been any changes. Some life-threatening causes include irregular heartbeats and brain aneurysms. Non-life-threatening events include receipt of bad news or experiencing fear or unpleasant sights such as blood. You can have what they call a psychogenic shock, and patients pass out, they wake back up, and they're fine. Hypovolemic shock is a result of an inadequate amount of fluid and or volume in the circulatory system. So it could be vomiting, excessive diarrhea, to significant blood loss, whether it be internal or external. Also occurs with severe thermal burns, where intravascular plasma is also lost. Dehydration or the loss of water or fluid from body tissues can also aggravate shock as well. So fluid loss may be the result of severe vomiting or diarrhea, which we already covered. A patient with severe chest injury may be unable to breathe an adequate amount of oxygen. So in this case, an insufficient concentration of oxygen in the blood can produce a life-threatening situation as rapidly as vascular causes of shock. So if you have respiratory insufficiency, get these people on oxygen. And also they might require some pain management to help them breathe a little bit better. Anemia is an abnormally low number of red blood cells. Hypoxia occurs because blood is unable to deliver adequate amounts of oxygen to the tissues. Sometimes patients that are anemic may actually show a pulse oximetry of 100%. No different than a patient that has carbon monoxide poisoning. The same thing. So again, pulse oximetry is a tool, but is not definitive on your treatment. If the patient says they're short of breath or have respiratory efficiency, we still need to make sure we're giving them oxygen. Certain types of poisoning may also affect the ability of cells to metabolize or carry oxygen. So carbon monoxide poisoning, the other one would be cyanide poisoning. When we get into toxicology, we'll cover more stuff on cyanide. So the stages and the progression of shock. So compensated shock early stage, when the body can still compensate for blood loss. So you might see tachycardia, but the blood pressures may still be normal, or you may see a little bit of hypertension. Decompensated shock is a late stage where blood pressure starts to fall, hypotension, and you may start seeing bradycardia as well. You start getting into irreversible, there's no way to come back from that. There's no way to assess when effects are irreversible at that point. You must recognize and treat shock early. This is why it's so important to get these patients lying in a supine position to distribute the load so it's not so concentrated. Lie them down flat, get their feet elevated, what they call a Trendelenburg position, get the patient warm, give them oxygen, and then you call for ALS, get them fluids. Monitor vitals every 5 minutes. So some signs and symptoms of progression of shock. So compensated shock, obviously agitation, anxiety, restlessness, feeling of impending doom. When they say, I am going to die. I feel like I'm going to die, impending doom. Altered mental status, rapid, weak, thready, or absent pulse. Clammy, pale, moist, cool skin. Pallor with cyanosis around the lips. Shallow, rapid breathing. Air hunger. The shortness of breath. Nausea, vomiting, capillary refill of longer than 2 seconds in infants and children. Marked thirst, narrowing pulse pressures. We start seeing decompensated shock. You'll see a falling of blood pressure, systolic blood pressure of 90 or less in an adult. Labored or irregular breathing, ashen, mottled, or cyanotic skin, thready or absent peripheral pulses, dull eyes or dilated pupils, and poor urinary output. So blood pressure may be the last measurable factor to change in shock. You're going to start seeing heart rate changes way before, and skin color and temperature changes as well. Particularly true in infants and children, because in infants and children, they have the ability to maintain homeostasis for a longer period of time. But the problem with kids is they'll maintain and maintain so well that eventually they'll just drop, and they drop quick. So expect shock in many other emergency medical situations as well. And pay attention to kids. Also expect shock if the patient has one or more of the following conditions. Multiple severe fractures. Reason being, your femurs each can carry 750 mLs of blood with a femur fracture. Your your pelvic cavity can carry 3,000 mLs, 3 liters of blood. Your total blood volume normally in a normal adult is 5 to 6 liters. So half your blood supply can leak out into your pelvic cavity. Abdominal or chest injuries, spinal injuries, a severe infection like sepsis, major heart attacks causing cardiogenic shock, anaphylaxis. So, see and size up. Be alert to potential hazards to your safety. Remember, see and safety BSI. Use gloves, eye protection for trauma scenes if bleeding is suspected. Remember, wearing masks in every call. In incidents involving violence, make sure PD is on scene prior to your arrival. Primary assessment, perform a rapid exam, head to toe. Quickly, 60 to 90 seconds, get it done. Determine the level of consciousness, identify and manage any life-threatening concerns, and determine priority of the patient and transport. This is a priority 1. Is it life-threatening? We need to load and go. Start for your additional resources as needed. As you're going through, you're going to provide high-flow oxygen to maintain perfusion. So high-flow oxygen, in this case, is going to be a non-rebreather at 15 liters per minute. For hypoperfusion, treat aggressively and provide rapid transport. Lay them down flat, supine position. Get them in a warm blanket. If you have heated blankets, put heated blankets on them. Keep that blood flow moving. Request advanced life support as necessary. Now, if your advanced life support is not available and they're farther away, transport at the BLS level and right to the hospital. Don't wait for an intercept. Don't ever pull over and wait, because your true care is at the ER. So that might be the document. Closest available ALS was the emergency department. That's perfectly fine. Your primary assessment, obviously form a general impression. Sick or not sick at this time. Assess the airway to ensure it's patent. Do breathing assessment as well. And an increased respiratory rate is often an early sign of impending shock. So to you guys, what is the normal respiratory rate for an adult?
12 to 20?
12 to 20.
12 to 20 it is. All right. So an increased respiratory rate of greater than 20, we need to start thinking of that potential for shock. Now, if they're COPDers and their oxygen saturation is 92% and they're breathing 24 times a minute, that might not be shock. That's just the way they breathe. So again, look at your assessment that you have in the patient in front of you. Assess the patient's circulatory status. What does it look like? Skin color and temperature, pink, warm, and dry, cool, clammy, diaphoretic. What is their body temp? Are they hypothermic? That's what will happen if the patients are in shock. Their body temperatures will start to drop. Then we're going to check their heart rate. A rapid pulse suggests compensated shock. In shock or compensated shock, the skin may be cool, clammy, or ashen. And assess for and identify any life-threatening bleeding and treat it at once. So if they have a major bleed, arterial, tourniquet, move forward, right? Continue on with your assessment. Next thing would be is determine if the patient is a high priority and if ALS is needed and to which facility to transport to. So know your area that you're in. I'm not going to tell you what to do around here until you're on clinicals. Because if you're working out in North Berwick, if you're working in Sanford, if you're working in Biddeford, it doesn't matter where you work, Maine, New Hampshire, you need to know an area and what your hospital capabilities are and how far away it's going to be. For us, where we are, some of our transport times at minimum are 45 minutes to a critical access hospital that's not level 1 trauma center. So out in the valley here where we are, some transport times take a while, depending on where we're located. Trauma patients with shock or a suspicious mechanism of injury generally should go to a trauma center. Your trauma centers are Maine Medical Center, Portsmouth Hospital, and those are your trauma centers. History taking, obviously determine the chief complaint, what's wrong, what's going on. And obtain a sample history, so signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events leading to illness or injury. The secondary assessment begins by repeating the primary assessment, followed by focus assessment. If a life-threatening problem is found, treat it immediately. Obtain a complete set of baseline vitals, complete set, and use monitoring devices from there. But your baseline set of vitals should be manual because that's the best course of action. Then use an automatic blood pressure cuff for trending from there. Reassessment, obviously reassess the patient's vital signs, any interventions that you've done. Reassess the chief complaint because if one complaint got better, there may be a different one coming at you. ABCs again, and reassess mental status, person, place, time, and event, and using your ABPU scale as well. Determine what interventions are needed. We're going to focus on supporting the cardiovascular system. We're going to treat for shock early and aggressively by providing oxygen and keeping the patient warm. I can't stress that enough. Patient needs to be warmed up. As soon as you recognize shock, begin treatments. Follow standard precautions. Again, if they're bleeding, wear a gown if you have to. But at minimum, it's face shield, eyeglasses if you have them, mask obviously nowadays, surgical mask, gloves, and things like that. Control all obvious bleeding. After we've tourniqueted stuff and things like that, the next step we want to go down is going to be controlling any other kinds of bleeds, like venous bleeds or things like that, where we can apply pressure and do pressure bandaging. Maintain inline stabilization if necessary, and check for breathing and pulse. As soon as you recognize shock, begin treatment. So again, comfort, calm, and reassure the patient. Never allow patients to eat or drink anything prior to being evaluated by a physician. If spinal mobilization is indicated, splint the patient on the backboard. Again, we don't do a lot of spinal stuff, so if it's a scoop stretcher onto that, that's perfectly fine too. And provide oxygen and monitor the patient's breathing. We're going to place blankets under and over the patient to keep them warm from all sides. Keep in mind that backboards are cold. So put a blanket down first, right, and then consider the need for ALS. Do not give the patient anything by mouth, no matter how urgently you are asked. Nothing oral, so no drinks, nothing like that at all, because if they require surgery, they have to have an empty stomach. Accurately record the patient's vital signs approximately every 5 minutes throughout the treatment and transport. Treating cardiogenic shock. Remember, a patient cannot generate the power to pump blood through the circulatory system. Chronic lung disease will also aggravate cardiogenic shock, and patients in cardiogenic shock should not receive nitroglycerin as they are already hypotensive. So if they say they have chest pain, it's probably because of the cardiogenic shock they're in, but if you treat it like a cardiac issue and you give them aspirin and nitro, you're going to kill the patient. So again, that's why we want to make sure we're looking at all of our signs and symptoms and our vital signs before we start making determinations on what we're going to do. Patients usually have a cardiogenic shock, low blood pressure. You'll see hypotensive, weak irregular pulses, cyanosis, about the lips, underneath the fingernails, anxiety, and nausea. One second, I gotta get back to one of you guys on here. All right, I want to reply back to one of the messages. All right, so place the patient in a position that eases breathing as you give high flow oxygen. So again, have them sitting up maybe in a semi-Fowler position. We're going to assist ventilations as necessary. So obviously if they're breathing too slow or too fast, we're going to ventilate them with a BVM. Provide prompt transport. Consider meeting ALS en route to the hospital, and provide calm reassurance to the patient with a suspected heart attack. So again, if you're suspecting an MI, we want to make sure we get them to the closest appropriate facility. And if you are here with us in this valley, like when you guys do your transport stuff, if you have a paramedic on board, we're going to bypass through STEMI bypass protocols and get these patients to a cath lab. So again, follow local protocol you have for that setup, whether it be Maine or New Hampshire. All right, for treating obstructive shock, For cardiac tamponade, increased cardiac output is the priority. So high flow oxygen and surgery really is the only definitive treatment. So they need what they call a pericardiocentesis, uses a needle to withdraw blood. This is an advanced skill rarely performed in the field. I have never seen it done in the field, at least not in New Hampshire or Maine. So again, it might be something that you need critical care transport for. And I'm sure they're not going to be doing it in the helicopters as well. They probably can do it, but if they're going to do it, they're doing it in the back of the ambulance before they go onto the helicopter for the ride. For tension pneumothorax, same thing. Chest decompression is required. Apply high flow oxygen, prevent hypoxia, get ALS early if available. Do not delay transport. This patient's going to get a chest tube at the hospital. Septic shock, again, I call it the silent killer. That's why I'm doing a lecture on it tomorrow. So hospital management is required for this. They need antibiotics. They need 2 rounds of antibiotics. They're going to get a fast-acting antibiotic like Rocephin or ceftriaxone or something like that. Then they're going to go probably with Zosyn and other different antibiotics as well. So there's a lot of different things they're going to be utilizing for these patients, along with potential for fluids and also pressors. So these are things that even paramedics can't do in the field, at least not in Maine, other than giving a pressor for blood pressure. So again, hospital transport is key for these. Administer high flow oxygen. Ventilatory support may be necessary. These patients may be breathing rapidly. So use blankets to conserve body heat because they can get cold. And then when you're calling into the hospital, you want to make sure you say, we're coming in with a sepsis alert. Because what they're going to do is they're going to start getting stuff ready because they have to draw lactic readings, they have to draw cultures, a whole bunch of stuff has to happen in the ER before that goes into play. Neurogenic shock for the spinal cord injury patient, use a combination of all known supportive measures that you have. And hospitalization will be required for a long time for these, for neurogenic type shocks. So emergency treatment would be obtain and maintain a proper airway, provide spinal mobilization, assist in adequate breathing, so they're breathing too fast or too slow, assist them, conserve body heat, transport, and ensure most effective circulation. So again, if lying them down, obviously they're going to be supine anyways, maybe the best option for these guys and maintain a good airway. Anaphylactic, administer epinephrine. This is one of the things that EMTs can do to help save a life right here is epinephrine. We carry it at the EMT level, and it's a phenomenal medication. I think very underutilized for other aspects in EMS care that a lot of paramedics don't even use when they should be using it. Promptly transport this patient to the hospital. They need to get there because, again, you only can give so much epi in the back of the ambulance. So when you give epi, it can wear off within 5 to 10 minutes, and the anaphylactic could come back depending on the severity of it. Also, continuously reassessing ABCs. Provide high flow oxygen, ventilatory assistance en route. A mild reaction may worsen suddenly. So again, they may have tachycardia and feel like they can't breathe, but the angioedema or the swelling of the tongue could then change itself within minutes. So continuously reassess this patient. Treating psychogenic shock in an uncomplicated case of fainting. Once the patient collapses, circulation to the brain is restored. So a lot of times these patients are perfectly fine. They end up being a patient refusal. But psychogenic shock can worsen other types of shock if the patient falls, or then make sure you check for injuries as well. So they could have hit their head, causing a type of a brain bleed or things like that. So you just got to look at the patient and do a full assessment. If the patient reports to being unable to walk after a fall, suspect another problem. So do your rapid trauma assessment, and then do more of a detailed assessment after to see if there's any injuries you may have missed. We're going to transport the patient promptly, record all initial observations, and try to learn from bystanders. If the patient has complained of anything or how long the patient was unconscious for. That's going to help determine a lot of things and how long they were unconscious for. For treating hypovolemic shock, we're going to control all obvious external bleeding. So if you see any kind of major bleeds, we're going to tourniquet and or apply pressure dressings. We're going to keep the patient nice and warm, bottom and top. Warm them right up, heat packs inside. Keep this patient warm. We're going to recognize internal bleeding and provide aggressive support for these patients. We're going to secure and maintain an airway and provide respiratory support. So again, oxygen, anything that is needed that way. We're going to transport as rapidly as possible. If it is a traumatic event, we need to get to a trauma center. So know where your trauma centers are located, whether it be Main Med. Biddeford can handle it as well. If you're looking over here, trauma centers would be Portsmouth. And that's pretty much it, unless you go over to Concord Hospital over in Concord area. Secure and maintain the airway for treating respiratory insufficiency. Clear the mouth and throat of any kind of obstruction. If necessary, provide ventilations with a BVM. So again, if respiratory compromise, just treat the respiratory compromise that's there and try to fix it. If it's an obstruction, remove the obstruction by using abdominal thrusts. Administer supplemental oxygen and transport the patient. Shock in older patients. You got to remember one thing about the elderly. They can't compensate like a normal, like a middle-aged adult or even younger. So the older you get, the harder it is for you to compensate for certain things. Also, on top of that, they may be taking medications that mask or mimic the signs of shock. Again, patients that are on beta blockers, right? Shock is going to increase heart rate, but beta blockers are designed to lower blood pressure and lower heart rate. So if they're on beta blockers or they're on other medications to control, like say atrial fibrillation, bring their heart rates down, like they're on diltiazem, you may have a patient that's in shock and they're not going to show it via heart rate because they're being controlled by medicine. So you may say, oh, there's nothing wrong with this guy, let's sign him off, but in all reality, they're bleeding internally somewhere, or something like that. So you just got to pay attention to those. So use caution when caring for the elderly and look at their medication list, and that's why pharmacology is so important. Older patients may also have more serious complications than younger ones as well. Illness is not just a part of aging. All right, so do you guys have any questions on shock at all? How do you guys feel?
I'm good.
All right, so let's go over the 10 review questions, and then we'll talk about next week again really quick, and we'll call it a night. So the term shock is most accurately defined as
Z?
B.
D.
all right, let's go see what it is. The answer is B. Shock or hypoperfusion refers to as a state of collapse and failure of the cardiovascular system or any of one of its components, heart, vasculature, blood volume, which leads to inadequate perfusion of the body's cells and tissues. Number 2, anaphylactic shock is typically associated with
B.
the answer is A, urticaria. Anaphylactic will have hives. So you'll see hives and whatnot, which is called urticaria. It's typically associated with an allergic reaction, mild, moderate, or severe. And they are caused by release of histamines from the immune system. So in anaphylactic shock, urticaria also is accompanied by cool, clammy skin, tachycardia, severe respiratory distress, and hypotension. Number 3, signs of compensated shock include all the following except
A.
I'm gonna go with D.
C.
D.
the answer is D. So in compensated shock, the body is able to maintain perfusion to the vital organs of the body via the autonomic nervous system. So signs include pale, cool, and clammy skin, restlessness or anxiety, a feeling of impending doom, tachycardia. When the body's compensatory mechanism fails, the patient's blood pressure falls. Absent or weak peripheral pulses indicates this. So number 4, when treating a patient, a trauma patient, who is in shock, Lowest priority should be given to what?
B.
Right. The answer is C. So critical intervention for a trauma patient in shock should include final precautions. As you can see the rest here. All right. Number 5. Potential causes of cardiogenic shock include all the following except.
B.
E.
C. Cardiogenic shock is caused by inadequate function of the heart or pump failure. All right, number 6. So a 60-year-old woman presents with a BP, blood pressure, of 80/60, a pulse rate of 110, mottled skin, and has a temperature of 103.9 degrees Fahrenheit. She is most likely experiencing what?
A.
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 A is a great answer. Septic shock. I'm glad you guys picked up on that. Good. Makes me so happy. Number 7. A patient with neurogenic shock would be least likely to present with what?
C.
C.
The answer is C. Good job. All right, number 8. A 20-year-old man was kicked numerous times in the abdomen during an assault. His abdomen is rigid and tender. His heart rate is 120, respiratory rate of 30. You should treat this patient for what?
D.
Let's see, D, D,
D.
D. The answer is D, hypovolemic shock. All right, so number 9, there we go. A 33-year-old woman presents with a generalized rash, facial swelling, and hypotension approximately 10 minutes after being stung by a hornet. 70 over.
A.
Look at that. You didn't finish reading it out. You guys are already yelling out the answer. The answer is A, epinephrine. Thank you for bringing that up very fast because it's quick treatments. And number 10, all the following are potential causes of impaired tissue perfusion except
A.
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 A it is. Remember, we decrease the number of red blood cells with tissue perfusion like that. All right. All right, so you guys have any other questions at all?
I do, Kevin.
Yes.
Epinephrine is something that at our level we'll be carrying and we'll be able to administer.
Yes. So you'll have it in 2 different forms. So for New Hampshire, you can either have EpiPens, but since they're so expensive, the state created something called Ready Check Inject, which allows you to draw epinephrine out of a vial and administer it. But there's a special program you have to go through to be able to administer it. It's not something you can just go ahead and give. Did that answer your question?
Yeah. I was wondering, well, I took this class 20 years ago, so, and I let it lapse, but it's interesting how much has changed in that time. Is that something new then?
It's been around probably about 10 years or so for epinephrine for EMTs, probably a little bit longer than that.
That's great. I was unaware of that.
Yeah, so it's been around, but the Ready Check Inject is new. Since EpiPens went up in cost to $600-700 a pen, they've gone up so much in price that they came up with the Ready Check Inject program because they're like services, we're not buying them anymore, so that's what happened.
Awesome, thank you.
I have a question.
Yes, Kim.
In reference to the NIMS training, I'm having a hard time finding the has power certification that we need to give to you.
Okay.
Is there a
Have you?
is there a link?
I can email you the link when I get done with the lecture here today. I'll shoot you an email with the
Okay.
link for the TEX website, and then you should be able to find the HAZWOP or AWR 160 on there.
Okay. All right. Thank you.
You're welcome. Anybody else have anything else at all?
No, I'm all set. Thank you.
So to kind of recap after we talked about the beginning of the lecture, no class this Sunday. This weekend we have off. Our first in-person lecture or in-person class is going to be October 3rd, which is a Sunday in Tamworth at 570 Plains Road in Tamworth, New Hampshire, which is the Action Ambulance base, where we'll be doing an 8-hour practical session. After October 3rd, please make sure you guys have with you in writing the dates you are available for clinical ride time.
Is that 9 o'clock?
9 o'clock in the morning, yes.
Okay.
Run 9 to 5. We'll take an hour off for lunch. There's plenty of places to eat out here, including barbecue if you want it. West Ossipee has quite a bit of food out here, so it's up to you guys what you'd like to do. But I do need to have the ride time schedules completed. I'm also going to have waivers of third ride waiver forms I need to get you guys for Action Ambulance so you can start your ride time. If you are interested in riding in Berlin, which is obviously a lot farther away, if you have an interest to see a different style of EMS and more of a city type in the city of Berlin, let me know and I'll set you guys up there with Scott Lees, who's the operations manager up there, and he'll set up your ride time. But I just need to know who wants to go up that far. Other than that, all the ride time will be done at Action Ambulance. Just let me know. Like I said, I need to know your dates you want to ride. Remember, you have to have a minimum of 36 hours, and you have to have 10 patient contacts. So when we talk about it on Sunday, I'll tell you guys more of the busy days that we have too. So other than that, please make sure you guys get your immunization records in as soon as you can. For those who have not paid yet for the September 1st, please make sure you get that September 1st payment in, and October 1st payments are due on October 1st. So just make sure you get that stuff in for me. And then I should have a grade for you guys after your exams and everything else for October 3rd as well. I'll try to pull you guys aside one-on-one and let you guys know what your current grade is as well, so you can keep track of that. Other than that, that's all I have. The recording, I'll complete that now, and that will be up on the YouTube channel probably in the next half an hour or so.
Awesome.
Thank you.
All right.
Cool. Have a good night.
You too.